I know there's a bunch of gastroenterologists on board, so please jump in because you probably know a lot more about this than I do. And I'm really excited about sharing different perspectives across the world about this. I also talk super fast, so please interrupt me if I'm going too fast. So I don't have any financial conflicts. I could use some financial conflicts. I have 2 kids in college. I really need some conflicts. I love Thai food, and most of the slides were actually borrowed from Dr. Sikkitis, so I really appreciate the help. So colon cancer is, we're going to talk about the problem of colon cancer around the world, current guidelines that differ based on your age and your risk. We'll talk about the different screen tests that are available and the evidence for why we use them. Some of them have better evidence than others. The difficulty with compliance with colorectal cancer screening, and then if you're not average risk, then how do we screen? So colorectal cancer is the 3rd most common cancer in the world and the 2nd leading cause of death in the world. It's interesting because in the US it's the opposite. It's the 2nd most common cancer in the United States and 3rd most common cancer killer, but it's about 2 or 3. In the world in 2020, there's almost 2 million new cases of colon or rectal cancer. The highest incidence appears to be in Europe, Australia, and New Zealand. And the lowest incidence is in Southern Asia and some African countries. The mortality was almost a million people in 2020, which is the beginning of the pandemic. And that's from colorectal cancer specific. So in the US, there was actually a task force of experts that came together and reviewed the literature and decided what are we going to recommend for our citizens in terms of screening for colon cancer. For the longest time, we screened only people from 50 to 75. And that had the most evidence, and that hasn't changed for a long time until 2021. In 2021, and we'll go over that in the next slide, we've noticed an increased incidence of colon or rectal cancer in people below the age of 50. So in 2021, numerous societies actually lowered the threshold for screening for colon or rectal cancer to 45. And then so now it's 45 to 75 in the United States. Or between 76 and 85, it's selective, so depending on how healthy people are, it's a risk-benefit discussion with their primary care provider. And then over 85, we stop screening. So there is also a multi-society task force. So 3 different gastroenterologic associations within the United States banded together to review this because they have the special, unlike the task force which reviews prostate cancer screening and breast cancer screening, these people screen colon cancer every day. So they came to similar conclusions, but they also said that they would screen from 45 to 49, and they gave their justification by saying, if you look at the incidence of colon or rectal cancer in a US database called the SEER database, it's called Surveillance, Epidemiology, and Results database. It's a cancer database. For 45 to 49-year-olds, the incidence per 100,000 was about 26 to 30. And before we started screening for colon cancer, that's the exact same incidence as people who are above the age of 50. So they're saying that, wow, before we started screening for colon cancer, the incidence of 45 and 49-year-olds now is the same as before we even started. And if you also look at the mortality for decades, so 40s, 50s, 60s, 70s, well, in 70s, the mortality is going down for every decile of age, except for the 45 to 49-year-olds. They're actually going up, which makes sense if we're not screening them. And then of all the colon cancers, at least in the United States, 11% of them are actually below the age of 50. So right now, multiple societies are starting to screen at 45. They also agree with the U.S. task force that screening over 75 is done selectively for 76 to 85, and they don't screen for 85. What's interesting about the multi-society task force is it's the only recommendation that takes life expectancy into consideration. So if your life expectancy is less than 10 years, even if you're 55, that maybe you shouldn't be screening them because they have bigger problems to address. This is where you get your screening colonoscopy and the patient has COVID, needs a heart transplant, is in renal failure, is a cirrhotic with a MELD score of 50 and needs a liver transplant. Those patients probably don't need a screening colonoscopy. That actually isn't addressed in other recommendations, and that's actually really, really smart. So what are the different tests that we can do? Well, being a colorectal surgeon, I'm a big fan of poo or stool, so let's start with stool. That's something I know a lot about. There's other things I don't know much, but I know a lot about stool. So the fecal occult blood test is a test that tests for blood. Not human blood, just any blood. So basically, what you do is you take 2 to 3 stools, and then you swipe it, and then you stick it on the card and wait for it to dry, and then you mail it. The important thing is that you do multiple stools that you swipe, and you send it in. And you have to avoid certain things like red meat and certain vegetables because, one, the red meat has blood in it, animal blood, which would be detected, and then the different vegetables will trigger the horseradish peroxidase and then give you a false positive. Now, even though this is the go-to test that every PCPL looks at, the sensitivity for cancer itself is actually not that high. It's 60 to 70% for colorectal cancer, and it's actually different depending whether it's proximal or distal. And then the detection of advanced adenoma, so a polyp more than a centimeter, or having high-grade dysplasia, or having villous features is only 10 to 11%. So not the best. So they've actually moved to other stool tests that are a little bit more sensitive. And the interesting thing about fecal occult blood tests is 2 things. One is, if it's positive, you need to have a colonoscopy. Just because you sent in a card doesn't affect your ability to have or not have colon cancer. So that's something that you need to take into consideration when we talk about the efficacy of the fecal occult blood test, because the reason why it works is because it scares people into getting the colonoscopy. There are actually 6 randomized trials. These are 3 of those, which I stole from Dr. Sickes' talk, where it decreases the mortality about 22% if you pull out all 6 trials at 30 years. So if you follow these patients for 30 years, you'll decrease your incidence by 22%. Now, I want you to remember the 30 years, because later on in the talk, we're going to talk about a randomized prospective trial that looks at decrease in mortality at 10 years, okay? So fecal occult blood test clearly is easy to do, not expensive, and it saves the lives from colon cancer. So it makes sense that we use this, and it's actually not that expensive. But then we have a sexier test. The sexier the test, the more expensive. So let's talk about the fecal immunohistochemistry test. So basically, that's also a stool test. It uses an antibody against human blood, so it's more specific. So I can actually go to my local steakhouse, eat a prime rib, and then go do my FIT test and not have a false sensitive. Now, if you remember, the fecal occult blood test was 60 to 70% sensitive for cancer. The fecal immunohistochemistry test is slightly higher, 74%, and for cancer, and about 24% for advanced adenoma, whereas only 10 to 11% for fecal occult blood test. So that's actually nice. You only need 1 stool. You don't need to change your diet. It's more sensitive for cancer and adenoma, and has not a huge false positivity rate, which is about 5%. That's actually really nice. More recently, it's easier for patients just to do a single swab and then mail it back in. Okay, so and that's actually a common reason for us to do screening colonoscopies, because the colorectal surgeons here are helping our GI colleagues because they're just overwhelmed by the number of patients who need screening. So then, if we only have a 74% sensitivity to cancer, we can do better. So let's go more expensive. So we're going to go with a FIT test, the previous immunohistochemistry antibody test, and we're going to add what they call multi-target stool DNA. So small pieces of DNA that are specific for colon cancer that are shed by cancer cells that can be found in stool. And basically, it's a combination of FIT plus those DNA tumor markers. So we increase our sensitivity to 92.3%, which is pretty good. So if my son came home with a math test of 92.3%, I'd be a little disappointed, but I would accept that. I wouldn't accept the 73.8%. It's not sensitive for advanced adenomas. It's only 42% for adenomas, and has a 13% false positivity rate. So the price you pay for increased sensitivity, besides the cost of the test, is that you're going to have a lot of unnecessary colonoscopy. Okay. Again, for both of these tests, the antibody test, which is specific for human blood, and then the stool test, which includes both human blood detection and tumor DNA detection, that you need to have a colonoscopy for it to do anything. So I don't know if this GI person is on the line, but he actually gave a talk at Digestive Disease Week last week on looking at, is there any way we could increase the negative predictive value of a FIT test? Meaning that if a test is positive, is there any way we could decrease the number of negative colonoscopies? So they added fecal calprotectin, and in their model, the fecal calprotectin, which is typically used by IBD doctors to look for inflammation in the colon, suggesting that their patients are having a flare and need more medical management. But they added the test to these patients. So they on the day of colonoscopy, they did a FIT test, they did a fecal calprotectin test, and then they scoped them. And they were trying to say, is there anything that predicts whether you can find a polyp or a cancer in the colon? And what they found is that if you have no symptoms, so it's a true screening colonoscopy, so no abdominal pain, bleeding, change in bowel habits, and your FIT test is negative, and your fecal calprotectin is negative, they had single digit, they had like 3.9% of them had lesions. So that's actually pretty interesting. I mean, it's not part of any, it's new and upcoming. So I was just curious if that person were here, but he's from Siraj Hospital. So other things. So we can test stool, or actually we can look at the colon. We can just look at the colon. So we can do CT colonography. CT colonography is where basically what send patient lies on the table, they drink their coffee, they read the test, they drink more coffee, right? So the CT colonography is done every 5 years. They actually dropped dual contrast barium enema from the screening guidelines, and we just use CT colonography now. The problem is that when you do CT colonography, you need a colonoscopy. You find anything, because if you find a polyp, you have to do something with it. Let's talk about CT colonography. So these are CT. This is a CT that we're used to seeing of the abdomen. And what it basically does is, by taking multiple images in a 2D, you reconstruct it in a 3D, so the radiologist looks like they're flying through the colon, and they can see if they can find polyps. So here's a picture of what maybe a cancer would look like on. And this is a picture of the same cancer on the 3D view that the radiologist is looking at. And this is one slice that was used to do the 3D reconstruction. This is from Dr. Sicker's talk. It's actually really, really pretty. So this is the lipoma, which is a nothing. You just look at it. And then this is the lipoma on 3D reconstruction on CT colonography. And this is the 2D version that they use to reconstruct it. So you can get really pretty pictures of CT colonography. So how accurate is CT colonography? Why don't we just do CT colonography? Well, if you look at the middle column, this is the topic we're talking about, which is screening, right? So in one Navy talk, they had a 94% sensitivity and a 96% sensitivity if the polyp is more than 10 milliliters. Okay, so like polyps that we're really concerned for finding, they can find them. The problem is that they're not so good if the polyps are smaller, and they can't remove the polyps. The other thing is sometimes they'll report things and we'll scope them and we find nothing, which can happen up to 75% of the time that we find nothing. And we're like, thank you for the business, but the patient was scared the whole time while they're waiting for the colonoscopy. Okay, so, but what if instead of just looking, we actually look and remove something, like removing the polyps? So if we believe that polyps will lead to cancer, what if we can do something where we can look and remove it, right? It's like, and at Christmas, you don't want to just window shop. You want to just window shop and go in the store and buy it and take it home, right? Or at least that's what my kids want me to do. So one test is a flexible sigmoidoscopy, which only looks in the rectum and the sigmoid. or maybe the descending colon. But most of the time, it only gets to the sigmoid colon, so only maybe the distal 15 to 20 centimeters. But it's interesting that they recommend this every 5 years. There's at least 4 randomized controlled studies that show a decrease in mortality up to about 26% if you pool all the trials together. So, and the reason why is because, a flexible sigmoidoscopy that shows anything triggers a colonoscopy. Because a flexible sigmoidoscopy will not affect cancers or neoplasia or advanced adenomas in the cecum or the ascending colon or transverse colon because you didn't get that far, right? It'd be like someone doing a mammogram and only getting the left breast and saying, yep, left breast looks good, so we're gonna let you go home, right? Another thing another option is you can do a flex sig every 10 years if you don't want to do it every 5 years, but then you have to do a fit test every year. Now, there was a randomized controlled study that compared flexible sigmoidoscopy to no screening, which showed that, flexible sigmoidoscopy is better than no screening. But they did a subgroup analysis where there's actually a flex sig versus no screening, but within the flex sig, some of them also got fit tests every year. And they showed that the flex sig plus a fit test has a way better decrease in mortality, right? Like 16% to 38% if you add the fit test. The problem is that it's a subgroup analysis. They weren't powered to find a difference, so it's not statistically significant. So we don't really say that you have to do one or the other, but and in some places which are resource poor, flexible sigmoidoscopy is reasonable because you don't need to have a GI expert to be able to do it because you don't have to get that far. You can have your PCP or your family practice person or your PA do this and at least get some screening. So I believe the best test is colonoscopy. And colonoscopy is typically done every 10 years, but colonoscopy isn't perfect. Depending on the quality of the prep and depending on the expertise of the endoscopist, there are miss rates where even if it's over a centimeter, 6% of the time we miss them. And as they get smaller, we miss more. And when we miss them, obviously, we're not treating them and they can become a problem in the future. So, initial studies were very encouraging for colonoscopy. There was a prominent study in 2012 with the New England Journal of Medicine where they looked at, okay, you do a colonoscopy, you remove a polyp, you follow them for a long time being 15.8 years was the median follow-up. And they looked at their mortality, so it's a cohort study. They followed them for 15.8 years after their polypectomy. And they found that they had a certain rate of death from colorectal cancer. And they compared it to a comparable group, which is just the general population that did not get colonoscopy. And they looked at their rate, and they found that it's 53% lower. So it wasn't a controlled study in the sense that they picked two groups and they randomized colonoscopy or not. It's just that they picked them against. They said, oh, the general population of the U.S. has a death rate from colorectal cancer of X, and the rate for this group is way lower. So we thought, okay, that makes sense. So flexible sigmoidoscopy can decrease the rate of mortality. And the reason why it does it is because it's always followed by colonoscopy. It makes sense that, a 20 to 25% decrease in mortality from fecal occult blood tests or flexible sigmoidoscopy would be even better if you did colonoscopy. That made sense to everybody in the world. And then our world changed in 2022. So in 2022, people from a group from Poland, I'll look at it, Poland and I think Norway and the Netherlands and one other country. They pooled all the resources and they did a randomized controlled study, okay, between approximately, so they accrued patients between like 2002 to 2012, and they basically randomized they took average risk men and women between 55 and 64, and they randomized to either a 1-to-2 ratio where the one group was, you were invited to have colonoscopy, and 2 is twice as many patients who were not invited to colonoscopy, which is just what they called usual care, or essentially at that time, there's actually no screening. They were being unscreened. So they were really stacking the deck for colonoscopy by saying, hey, you can go from colonoscopy versus no screening. It's gotta win, right? They were expecting a 30% decrease in incidence of colorectal cancer and a 50% decrease in mortality, which is similar to that last study we just talked about, right? The New England Journal of Medicine study, where if you remove one polyp, you follow them for 15.8 years, and you have a 53% decrease in mortality. They're saying, okay, we're gonna power our study to find that, okay? So they, they did for the one group where they invited to have colonoscopy, they just invited them. It's kind of like when Dr. Sickness invites me to a party, I don't go. So about 58% of these people did not get colonoscopy. Only 42% of them actually agreed to it. So I guess the Europeans really don't like colonoscopy, okay? And then they followed them for 10 years. So let's think about this. They did a randomized prospective trial, the gold standard for research in medicine, for saying that this actually works, right? And they followed it for 10 years, right? 10 years is actually not that long. I mean, my residents think it's a long time, but it's actually not that long. I mean, the National Polyp Study had a 15.8-year follow-up. The fecal cord blood studies, they were 30-year follow-ups. Those were the studies that found mortality difference, not a 10-year follow-up. So basically, not surprisingly, since so few people had colonoscopy, if you compare by intention to screen analysis. And the reason why they did that is because they randomized based on intention to screen. So either I'm going to screen you or I'm not going to screen you. And they randomized it so the two groups would be comparable, so we can actually say, yes, this worked. And they found 18% fewer colorectal cancers and no difference in mortality. And this was on the news every day for every news network in the United States, saying colonoscopy is a waste of time. And all my GI colleagues were thinking, oh my gosh, I'm out of work. I'm going to have to beg for food on the Portland streets, which is great because there's a lot of homeless people there. They have plenty of company, okay? But the thing is, they said, but wait. There's a subgroup analysis where what if we looked at the people who actually got colonoscopy? If you look at the people who actually got colonoscopy and compared them to the people who did not get colonoscopy after 10 years, what happened? They got exactly what they were expecting, which is a 31% decrease in incidence and a 50% decrease in deaths, which is what we all believe. It's what we expected, but they didn't actually screen enough people. So all of the editorials and the comments and the letters to this were commenting on, for example, in a lot of countries, we get maybe a 50 to 60% compliance rate with colonoscopy. So maybe that's why we're having better results. But the thing is, this is the only large randomized control study for colonoscopy looking at mortality, and it did not show a difference. So the interesting thing is they actually have two, they were expecting to report at 10 years and 15 years. So the thing is, in five more years, we may find a different result. Because at DDW, I was actually listening to one of the authors discuss this, and he was really sad that the colonoscopy didn't show a difference, but he's saying maybe we didn't wait long enough, because maybe at 15 years it'll make a difference. So we'll see. So let's think about this. So they reported it in 2022, which meant that their last accrued patient or last colonoscopy was in 2012, right? What has happened since 2012? Well, they had the iPhone. I think a couple of my residents might have been born. And we found that split preps work better for colonoscopy. So what's a split prep? A split prep is when you take half of the prep the night before and half the morning of, or if you have an afternoon one, you can just take it all in the morning. So the point is you want to get prep as close to the colonoscopy as possible, to the colonoscopy interval to be short. So you get a better prep, at least on the right side of the colon. And in 2014, they showed that the quality of the prep was better if you did a split prep. But in 2017, they showed that not only was the prep better, but you're more likely to pick up adenomas, any adenomas, and even advanced adenomas. So the thing is, we changed our practice for colonoscopy since that study stopped. We're basically just following patients. So the quality of the colonoscopy has changed. We've also have higher definition in colonoscopy devices, so it makes it easier for us to see things that we couldn't see before. I mean, anyone who's had the TB I had when I was in college could barely see two eyes and a nose on a football player, and now you can see the sweat off their face. So let's talk about, these are recommendations that we say, based on best evidence, this is what we should do to decrease the risk of colon cancer. So to my chagrin and shame, the adherence rates to these published rates in the United States are between 13 to 55%, depending on what state you're in, which is terrible. I mean, this is like D minus F territory. Actually, South Korea isn't much better. Even though they have BTS, they don't apparently care about colon cancer. But Thailand, way to go, 63% adherence in Thailand. So you have one of the higher rates of adherence. So good job. Not just good peanut satay, but you actually do colorectal cancer screening, so good job. But why don't people actually get screened? Well, maybe they don't think of it as a real problem. Like they think about heart disease and diabetes and COVID. They don't think that, well, colon cancer could get me because, I don't eat red meat. I'm vegetarian. I don't know anybody in my family who's got colon cancer, so it can't be me. And it's also the prep. The prep is actually awful. I had my first colonoscopy 4 weeks ago, and it was the worst 36 hours of my life. I was super hungry. I was super nauseated, and now I can appreciate what my patients go through. And I intentionally chose the worst bowel prep I could take, which is the full gallon of Go Lightly, because I wanted to get the full experience of the pain. And I got it. I was just miserable. And it's also expensive. In the United States, where our healthcare is very expensive, a lot of patients don't have access to colonoscopy. And then for our PCPs, they're trying to screen for so many things. Trying to screen for suicide, try to screen for breast cancer, prostate cancer, diabetes, hypertension, and then this is just another thing that their patients hate anyway. So in their 20 minutes, they may not cover it. And then there are like so many ways to screen for colon cancer, which is the best way, right? Unless you are a connoisseur of poo like me, you may not appreciate the differences between the different tests. So then there are actually ongoing trials in the United States, and I'm sure in other countries, where they're trying to address the inequity or the access issue to colonoscopy. So for example, one of the highest demographics in the United States are African Americans, Native American or Indians, and Alaskan Natives. They have actually the highest rates of colon cancer in the United States. So one of them addresses for our black patients, where they're trying to have peer outreach to a community that naturally distrusts, the government and the formal academic medical establishment because of the Tuskegee problems and multiple scandals between us and their treatment in the past. If you look at the third bullet, in Alaska, they're thinking of using Cologuard, sending Cologuard, mailing them out to people that live 150 miles away from the closest city. And Cologuard's easy. I mean, I actually watched the video. You just poop into the container, you do your fit test, and then you screw it on and you mail it back. And it's got a label on it. I mean, it's like foolproof. You don't have to drink a prep. It gets mailed to you, you poop into it, you close it, you mail it back, and then you have a 93% chance of detecting cancer in a population that rarely sees their doctors. And then they've actually developed a couple different tests, serum tests to look for screening. And so these are all in trial. These aren't prime time, but they're trying to address the issue of access. People who can't get the colonoscopy, people who won't get the colonoscopy because of the awful prep. So when we risk stratify, for us, anyone 45 or older, yep, you get a colonoscopy. You just gotta say, yep, I want it, you get it, okay? Or they can get screened by multiple other ways, like stool tests, or FlexSig or CT colonography, and if anything's positive, what you need to do is get a colonoscopy. And then, oh my gosh, how do I go forward? Okay, there. So people are at increased risk. So if you have a family history of colon cancer, now, 85% of the time, there's no risk, no family history. which is what throws people because they're like, well, I don't have a family history, so I don't need colon cancer screening. But at least 15% of them, actually have some history. And if it's a hereditary syndrome like familial adenomatous polyposis, MYH-associated polyposis, Lynch syndrome, they get screened at earlier times, and we'll talk about that in the next slide. For patients who have a family history, but they don't have a known syndrome, we just say, oh, fine. We will screen at 40 or 10 years below the earliest age of cancer in your family. And then inflammatory bowel disease, we'll talk about in the last set of slides. It's interesting, the chronic inflammation sets them up for cancer. And not only cancer, like invisible cancer, where you may not see it. And that's where we talk about different ways of doing colonoscopy to try to get them. For IBD, typically we wait for about 8 years after the diagnosis of pancolitis to start doing their scopes. So let's talk about the hereditary syndrome. So familial adenomatous polyposis typically leads to tens, to hundreds, to thousands of polyps. We start screening at 10 to 12. I actually have a 12-year-old, so I just can't imagine putting my girl through this. But the thing is, if they have a family member with FAP and a cancer, and they know the genetic mutation, you can screen your child for it. And if they don't have the mutation, you don't have to worry about it. But if they do have the mutation, you need to do a flex sig, starting at 10 or 12. Depending on the guidelines, it's either every 1 to 2 years. And basically, once you find polyps, just like we do for colon cancer screening, you switch over to a full colonoscopy. One is to look at the extent of the polyposis, and two is to remove the big polyps and get them through their tough teenage years before you talk about colectomy, proctocolectomy, pouch, where middle school is just not the time to do it. Okay. Then there's the Lynch syndrome or hereditary non-polyposis colorectal cancer, where we start doing colonoscopy at age 20 to 25, and we do it every 1 to 2 years, typically every 1 year. And then if you have a first-degree relative with colon cancer below the age of 60, or with an advanced adenoma below the age of 60, then you get your first colonoscopy at 40, and you do it every 5 years. What throws a lot of patients are like, well, I don't have anyone with cancer, but their dad had a 2-centimeter polyp. They belong in this higher risk group, and they need to be screened every 5 years. Inflammatory bowel disease, we'll talk about something called chromoendoscopy, which is somewhat tedious and somewhat expensive, but it's actually a better test, and we'll talk about that in a little bit. Okay. So what's an advanced adenoma? So an advanced adenoma is anything with villous features. So typically anything with more than 25% of the slide is villous is called either tubulovillous or more than 75% villous. If it's more than a centimeter, so a centimeter is what we use as big. It's the little bar that we say, okay, you're more than this, you're an advanced adenoma, or any high-grade dysplasia. All of these patients need to be screened as if they have not quite the same risk, but they are at elevated risk compared to other patients. So inflammatory bowel disease, sorry, my phone's going crazy. So the inflammatory bowel disease is interesting. There's an entity in general surgery called a Marjolin ulcer, where you have a chronic non-healing burn or wound for years, and then decades later you develop a squamous cell carcinoma from the constant healing, inflammation, rehealing, and then the constant turnover of cells lead to neoplasia. When ulcerative colitis, if you've had pancolitis for over 8 years, they can get dysplasia. It could be low-grade dysplasia, high-grade dysplasia, or cancer. But the interesting thing about this is that a lot of times it's invisible. Like you can't see it. You do your regular colonoscopy, you get to the cecum, it's a great prep. It actually looks pretty damn good, but you're missing stuff. So here's some pictures from chromoendoscopy. So before we give fancy stuff like methylene blue or indigo carmine, this is what it looks like. And then this is what it looks like if you make it blue. I happen to really like blue because both my kids go to University of Michigan and blue is their color. So our family bleeds blue. And this is how blue would change it. So you can actually see the pit patterns and the changes that are consistent with neoplasia, which you could biopsy or snare or remove. Okay. This is what you can see by chromoendoscopy, where you have to get to the cecum, hit the colon with a whole bunch of indigo carmine or methylene blue, and take your time and look. And typically when we do it, we have to book about an hour to an hour and a half. It's typically done with anesthesia because it's a longer case. And it's actually pretty time intensive, and not every institution in the United States has this availability. So the other option, which is predates chromondoscopy, is do a good quality endoscopy where you do 4 to 5 quadrant biopsies every 10 centimeters and having at least 32 biopsies. But what you'll see, okay, here's another picture where it looks actually not too impressive. And then there, it actually looks a lot scarier, okay? So there's actually a multi-center randomized controlled study from China where they compared high-resolution endoscopy and targeted biopsies, high-resolution endoscopy with random biopsies, the 4-quadrant biopsies every 10 centimeters, and then chromondoscopy. And they happen to use methylene blue. A lot of times in the States we use indigo carmine. And they clearly found significantly more dysplastic lesions when they did the chromondoscopy versus the regular endoscopy that we use for screening for colon cancer. So briefly, the big thing in 2021 is that we switched to colorectal cancer screening at age 45. The big thing in 2022 is the world had ended and colonoscopy doesn't work, so we don't have a job. But I think that there's some problems with that study, which is one is underpowered to find a difference. 2, they didn't wait long enough. And 3, 58% of them didn't get colonoscopy. Colonoscopy can't prevent something if you don't do it. So I think that the 15-year follow-up, which will happen in 5 years, so 2027, the Nordic trial will present their 15-year follow-up, may show a difference. But in the meantime, at least in the United States, we have not changed our paradigm of using colonoscopy as our gold standard. Now, some patients are not, can't get to, they don't have colonoscopy available. For example, in Oregon, we have 3 big cities. We have Portland, which is where we're at over here, Salem, which is our capital, and Eugene, which is a major university. But everything else is rural. And in the rural areas, there are no gastroenterologists. A lot of times, general surgeons or family practice people doing the endoscopy because that's all they have access to. And in that case, we know fecal cord blood tests or FIT tests work. Cologuard's a little expensive. At the VA, they're actually tracking, they're following a cohort of veterans that they're doing FIT testing for, and they'll probably publish data in the future because it's a captive audience and they're an older population and there's a chance that they may be able to see something, at least for FIT. So we know the fecal cord blood test, the regular, test to stock your diet for, clearly that works. But the FIT test is more sensitive. You'd think that would show a mortality difference, but it's too soon. I mean, it just came recently, and we'll see what the data shows for that. So anyway, I appreciate your time, your incredible patience for listening to me and tolerating my terrible jokes. I'm happy to take any questions about at least screening.
Thank you so much, Dr. Liu. Dr. Art, do you have any questions for them?
Right. Thanks, Dr. Liu. It was an outstanding talk and very fun with tons of evidences. So yeah, as we all know that we are trying to get the colonoscopy done as much as we can, and we're trying to make it high quality colonoscopy. So basically, I think we could go through the factors that would be facilitating high quality colonoscopy. But the first thing that I'm interested in, and I would like to have these numbers from your side. I'm not sure what's the incidence of interval colorectal cancer in your center.
I don't know what the incidence of colorectal cancer, at least our center is. It's actually a little bit skewed because we're the only university in the whole state. So we pull from the whole state. So we get a skewed version of reality because we tend to get the people who don't get a lot of care and then have delayed presentation. I would say that we do follow the quality of our endoscopies, and we follow, for example, like cecal intubation rates, we expect to be 95 plus percent. We expect withdrawal time to be at least 6 minutes. We expect the adenoma detection rate on a routine screening colonoscopy on an average British person to be around 30%. At least that's the incidence in the United States for both men and women. We expect roughly 30%. There used to be a difference between men and women, but now we expect the same amount for both men and women. And then we grade the endoscopists on their preps. So we've moved a lot to split preps. We have nurses who call the patients to double check that their preps are okay. And sometimes what we do is we give them additional prep and have them be scoped the next day, because if the prep isn't adequate, it doesn't make a difference how good the endoscopist is. You're not going to see what they need to see.
Yeah, I see. Thank you. That's a good number. But however, I'm not sure if you collected the data on interval colorectal cancer incidence.
That I don't know. Leanna, do you know?
No, I don't think we know our interval cancer because I don't think we even can capture it. I don't know how we can capture it with us because we're kind of a bigger group and we get a lot of our patients. So I can scope somebody, and if let's say they move somewhere else in Oregon State, they may get their colonoscopy because they had one symptom, whatever they complained about in another site, and they may find a colon cancer that I might have missed, like in 3 years instead of when I gave them whatever, the 7-year interval. I don't think we can capture that because it's not like they come always here. And so I wonder, like, how we could do this. Maybe we could do it in the state, but in our center, because as Kim very nicely alluded, we get a lot of but they're already diagnosed with cancer. So I don't know, and I don't know. And our gastroenterologist also, I know they do a lot of complex EMRs and they ask for patients to come when they need to come, but I'm not sure what the compliance to that is as well, or if they follow up on an interval colonoscopy or surveillance colonoscopy somewhere else. So unfortunately, this is the limitation we have.
But it is a very important question, because
That's a great question.
if you did a colonoscopy and they get a cancer the next year, then you know you missed it. And for quality control, you should know about that, because we should be constantly trying to get better. And if we don't measure it, we can't get better. But unfortunately, sometimes care in the United States is fragmented, and they may come to us for their first scope, but then a lot of patients don't like to travel. So if they can, they'll try to keep their care as close to home as possible, and we lose them sometimes.
Yeah, I think so. I would agree with Liana and Dr. Liu that it might be the whole image from the whole state of the country that could answer this question. Thank you.
How do you screen in Thailand? Do you do all stool tests? Do you go straight to colonoscopy? What is your preference for your screening?
Yeah, here in Thailand, there's no national program on colorectal cancer screening just yet, but the incidence is going up. Excuse me. I think the incidence of colon and rectal cancer in Thailand is in 1/3, perhaps like the second or the third sometimes. However, it's very expensive to launch standard national screening program for colon and rectal cancer screenings. But nowadays we do still fit test as the beginning. And once it's positive, then we would move on to colonoscopy, either, but we have options as well. CT colonography would be one of the options. And then, we do promo colonoscopy. We try to do, but it's time consuming, endo colonoscopy with AI, like endo brain automatic calculation of possibility of either in that particular advanced polyp, so on. And perhaps I think one of the sites from PDMS would be gastroenterologists as well, and then I'm sure pretty sure they performing ESD, EMR as well as for advanced early cancer.
Bangkok หาดใหญ่ สมิติเวช what kind of like screening you doing สมิติเวช
In terms of national screening program, right now the authority has added 2 years ago recommendation for the PIT screening to people of blood test for screen of the mass screening program in Thailand. But I think it just started, so maybe we still need to wait for some years for the information. And when the blood test positive, then they go for colonoscopy because we have more gastroenterologists. We have more surgeons who perform the colonoscopy in the tertiary care or the secondary care center in our country. But in terms of the stool DNA, I think still a long way to go. The stool DNA is too expensive comparing to the colonoscopy price in Thailand. I think in the private hospital, the price may be about $800 for the colonoscopy. In the hospital, in the government hospital, it's going to be like just 1/3 or 1/4 of the price, which is cheaper. For student care, I think it's almost more expensive than the government price for the colonoscopy. So in terms of the student care, it's still not yet worth in Thailand. And most of the patients people have stool positive, then they go for colonoscopy. In terms of our center, like our private hospital, so we do the screening regarding of the patient who has the intention to go for the full colonoscopy. We recommend them for the colonoscopy because we would like to detect the polyp when cancer. We would like to prevent the colon cancer. So in the patient who doesn't want to go for colonoscopy yet, we recommend them for the stool test and the regular stool test after 40, 55, or 45 or 50, depending on the risk. And one thing that I think we mentioned about the colonoscopy is the serrated polyp, which becomes more to the interest of the gastroenterology. Because the serrated polyp, which is usually it's a flat polyp, could be missed from some kind of screening protocol like the virtual colonoscopy or CT tomography, which maybe you miss the flat polyp. How do you think about this kind of polyp, which maybe it also has the significant risk of colon cancer change as well?
Okay. What about หาดใหญ่คะ or ขอนแก่น Okay, this seems like quiet. Okay, any question for Dr. Liu or Dr. Liana for today's presentations?
Lou, I have a quick question. Thank you for a great presentation. I really enjoyed the pacing and the sort of the depth of each option. One of the things you mentioned was the CIRA sort of colleague in Chicago. Was she proposing another test, or was it just a combination of existing tests?
Combination of existing tests. His talk was actually on patients with like lower abdominal pain and lower GI symptoms like diarrhea or rectal bleeding. And he was trying to sort out a model to say, well, we scope them because we're worried about inflammatory bowel disease or microscopic colitis or other things. But then also they want to get an idea of, can we predict cancer or polyps? And this was just their preliminary model, which included numerous things, including like C-reactive protein, but that didn't actually predict anything. It was just a fecal calprotectin, the FIT test, and then their symptoms, what they use in their model.
Thank you.
And then I wanted to point out that we actually do CT colonography, but we mostly do it for patients in which we cannot complete the colonoscopy. So if we can't get all the way to the cecum and clear the entire colon, we use CT colonography to make sure we're not missing anything. And unfortunately, CT colonography is hard for patients to think about because you still have to take that awful bowel prep. And then if they find a polyp, then you have to take that awful bowel prep again to get your colonoscopy, unless you're lucky enough to get colonoscopy the next day. And I am so grateful that it'll be years before I have to take that prep again. It's literally, it was close to the worst day of my life. So that colonoscopy was fine. The sedation was wonderful. It was the best 29 minutes of sleep I've had in my entire life. But because no one was paging me, my kids weren't yelling at me, and it was great. It was almost worth having a 6-foot thing stuck in my anus just to sleep for 29 minutes. So, but anyway, I appreciate your patience. Thanks for really good questions. And if you don't have any questions, I think we're done.
Do we have more questions before we end the session today? Do we have any question from Samiti Wade?
You can read first.
Samiti Wade, do you have any questions? Any more questions for them?
No more question.
Okay. Had Yai, do you have any more questions? Okay, that seems like quiet again. Thank you so much. I don't think that the rest have the question, but if you do, please.
One question.
Oh, yep.
Yeah. I'm not sure. Last question. Dr. Lu, is there any future for ctDNA as a screening tool?
So ctDNA right now is experimental for following colon cancers. I think the ctDNA is way more sensitive than CEA for surveillance after colon cancer. And it's actually really exciting because we're trying to figure out how best to follow people who have a rectal cancer, who get total neoadjuvant therapy and get a complete response. And we want to try to follow them in the most cost-effective way. And for us, the only people who can order ctDNA is actually our medical oncologists. I'm not sure why, but it's a idiosyncrasy of our medical system where for some reason they can only order it. And then because it'd be great to say, for sure you don't have cancer. So you don't need to have your big surgery and risk pelvic, sexual dysfunction, urinary dysfunction, that kind of stuff. And the patients will be relieved. But unfortunately, ctDNA right now is not quite ready. And it's not available at every institution either. But I think that it's an exciting thing that people are studying and following, and people are looking at biomarkers to predict a complete pathologic or clinical response for rectal cancer after treatment. But it's available at certain centers, but not everywhere. But it is exciting to think about.
Actually, Art, your question is great because there are a lot of malignant polyps that our gastroenterologist will remove, and then we find out they had malignancy. And then they send them to us, and I do the scope, and I cannot see the scar. So now how am I going to survey this patient? And this is not an uncommon case scenario that we find in our tumor boards. And so they say, oh, there is somewhere in the sigmoid. Well, the sigmoid is long, or the transverse colon is long. I don't know. I mean, if I don't see the scar, I don't know where it was. So we've been thinking, could we follow it with the ctDNA? But because the data of ctDNA is so all over the place right now, actually the latest in GI ASCO, when a year ago it was Panacea, and then we questioned it this past GI ASCO meeting, it's not there yet, and I cannot order it because I've been thinking, like, what do I do with those malignant polyps? They say margin positive for cancer. I cannot find the scar. The CT is too early to show you anything. And this is the only way that I was like, maybe ctDNA, and our medical oncologist cannot order, because I cannot order the test, as Dr. Lu alluded, like it's only medical oncologists here that can order the test. So they're like, there is no value. So it's a great point what you bring, but it's not a screening. It's more of surveillance for somebody that now I don't know how to survey, So I'm sure you have this phenomenon there. I mean, I think this is human nature. It's a national it's an international problem, but it may have a role in that, and that would be fantastic when we are able to do that. But it's not being studied. Even at least in the States, I don't know a study that is doing this, because it would be unethical if you know where the polyp is. A lot of people will do the surgery, because it's an early stage colon cancer. But yeah, I'm very curious to see how this is going to evolve. But it's a great question.
Thank you. That's interesting. Thanks, Liana. Thanks, Dr. Lu.
So last minute, any last questions?
Can I add 2 points? I mean, Dr. Liu likes to suffer, and he did the gallon of golightly for his prep. But there is soup prep. There are many other preparations in the market that are much more palatable and much easier to do. There are even the soup tabs as tablets. There are ways to make this easier for our patients. So I want to make sure that we give you all this information for your patients. And the second, when it comes to quality of colonoscopy, there are the national SEG standards that Dr. Liu also mentioned. But I do believe the inherent software you're using when you do your colonoscopy is an extremely important tool to follow your quality outcomes. So we use Provation, and within Provation, there are different iterations. It's a software. It's like our EHR for endoscopy. They have all the quality metrics, and now we are asked, and actually not asked, it's required, that everybody who does endoscopy incorporates that special template that gives you not only like which polyps you found, how you removed them, where you found them, and all the good things about prep. What was the score? Like a lot of other details that get incorporated to, and there we have a gastroenterologist, one of our therapeutic gastroenterologists, who does a query every few months on all these endoscopy reports, and then we get a report of how well we're doing. So if you are concerned, or you are interested in studying it, I would strongly recommend, and when we visit, we can bring you more details. But I think that is, it's an important metric, because you don't know what you don't know, and you don't know how to get better if you don't get any feedback. So that is, I think, a very important tool to do colonoscopies better, So I wanted to bring it up to you, because I know we did not mention it.
Thank you. That's it.
It's a clinical trial right now where they're actually looking at real-time feedback for endoscopy. So there's AI and your software saying, hey, it's only been 3 minutes since you pulled out. Hey, where did you remove this polyp? So it would like say, you might want to try a snare, Dr. Liu. Kind of thing. Like, hey, you missed something. Pull back. Make a left. Stop. So it's really interesting where people are using technology to try to improve our care, and it's really exciting. Actually, mostly it's my techs yelling at me, saying, "Hey, you missed something." Those young folks, man, they could see way better than me, because if my glasses get a little bit sweaty, it looks like one big blur. So I really appreciate their help. So anyway, thanks again for listening. I really appreciate it.
Now, when we come and visit, Dr. Liu will be the joker. Okay. Be prepared.
Wait.
Well-fed joker. Thank you all. Good to see you all.
Thank you so much. See you in a month. Take care.
Thank you so much.
Bye-bye. Bye-bye. Thank you.